clear, the advanced session is advanced in the sense that it's intended for those who are going to be working towards training. Being a trainer is the idea. So it's for us to, and it's great that it's a small group like this, because this could be a discussion, is what I would hope that it would be. So, I'll share some ideas that I have that have been from some years of doing this, as you have also. But we've got some excellent trainers here, so I think there should be some really good discussion. I hope we can capture all that on the video. I'm not sure if that will work actually.
And whenever someone has a question, I'll run the mic and we'll be able to understand that perfectly.
Okay, is it something like we could leave it on the table perhaps, just because yeah, because I'm sure this will be I would bet this would be active discussions that, and we are, what does the schedule say? We're scheduled to be finished by what time?
Noon.
Oh, we're golden. Shoot, we got good time then. So a little bit of this is to share a little bit of my story, because everybody has their stories for how they got involved in this. You shared a bit of yours this morning, which I thought was very interesting, and how that came about. But I think it's important to, and the reason I included this as the first slide for this discussion is, there has to be some reason you want to do this, really. It's not something that you just wake up one day and you just do it because. There has to be something that drives it, I think. And so sometimes these are events, like you described, someone came and said, why don't you do this? So there's a good event. And then you decide, yeah, I don't know why I never thought of that, as you said this morning, but yes, that's a great idea. Let's do that. I think if you, I know, Gene, if either of you guys, I don't think you've done any training. And have you done training?
No, but actually in Nigeria they're suggesting that.
Okay, so perfect for you to be here. And I'm sorry, I don't know.
Yeah, I work with MMI. I do trips to Bolivia and Peru.
Okay,
I'm the medical director in Peru, so I'm
fantastic.
getting more doctors that are coming that are young, and so I'm transitioning from doing the surgery to mentoring them.
Oh my goodness, we've got quite the group. I mean, I have no business doing the presentation here. You guys it'd be awesome. So anyway, see me as the facilitator then, please. This will be great to hear your perspectives on this. So then you know exactly what I'm talking about. I bet you have a story for how that happened, don't you? Yeah. Would you share just a little bit of that? We heard some of Gene's and.
Well, I'm not in an academic situation, so I'm not used to training people.
Want to hand him the microphone, if you would, please.
A couple of years ago, I was on a medical mission trip, and there's a doctor that does a lot of training, and he invited a resident to come. And then at the last moment, his mother got sick, the trainer, and so they asked me to train this guy. And I'm sitting there, and I think I got more, I aged about 10 years in that 1 week, and it was a third-year resident. So, I mean, he was just learning it from scratch. But the nice thing about a resident is that he was teachable. He would listen to what I say. Now I see these phaco surgeons that are coming in, and they know everything, and it's hard to teach them things. They're going to do it the way they want to it, and they get into so much trouble
so quickly.
And how to get out of that trouble. And we don't have an assistant scope, so I'm just looking over, and I'm running around doing other things. I have 2 or 3 surgeons working, and so it's difficult. So I want to learn better techniques of how to help mentor them, and when to step in. I step back, and when they ask for help, I do that. I'm more of I'm an introvert, so I'm not trying to take over a lot of stuff. And so sometimes I need to be better at when to intervene and when not to, and that sort of thing. So that's what I'm kind of here to help.
Perfect.
Find out.
And you may be doing some training in Nigeria, you said?
I haven't done it yet.
So fantastic.
So that's why I'm here.
Well, I think this will be quite appropriate, some of the material. So I have 2 talks, one on sort of an overview of teaching, and I've got a microphone here, so that should take care of that. Thank you. And then the second half is more about specific training pearls. So we'll be thinking about that as we have our discussion together. We'll maybe think of this in some broad strokes initially, and then discuss some of the specific training pearls. And with your talk also, I think that will work very nicely. So And I'll make sure it comes up on the screen here. So I saw your presentation is loaded here also, so we'll be able to get to it, okay? Okay. So I had to ask myself the question of who did I think I could even train? And you know, these FACOs are, you said it just right. So your question leads right into this, because it's like, you know, they don't want to learn sometimes. And so there's the problem of who in the world do you think you can really train? And the advanced phaco surgeons, it's more like, you know, kind of dabbling with it. And I found those are universally not successful. They just want to try a little MSICS, that sort of attitude. I just want to learn a little MSICS, that kind of thinking generally does not result in a successful MSICS surgeon, and really results in a frustrated phaco surgeon, because they never get past that idea that all I have to do is just mess with it a little bit and I'll get it. So they never get down deep enough into the mechanics of the technique to really know that there are differences that they have to pay attention to that will be counterintuitive for them as a phaco surgeon, particularly with regard to managing the anterior chamber, right? That's where they oftentimes struggle. They can, you know, do great with tunneling sometimes, but then they just can't stand it that the capsular bag is not, well, how come it's not just stretched wide open? And, you know, what's the deal? This is a terrible procedure, and, you know, and so on. So, you know, I understand the challenge with that. So who did I think I could train? Well, here was the answer that helped me a great deal. And this is such a simple thing, but I tell you, it has just proven itself so over and over again. Surgeons who had a good reason to learn. So one of the things that I work towards is when I'm training someone, I want to make sure that when I listen to what they're saying and their story about why they're there for training and so on, that it's clear that there's a good reason to learn. And that usually provides enough to get over those initial challenges. It may not, in the end, be enough to really go on to do a lot of MSICS surgery, but it's enough to get started, is what I would suggest. What do you all think about that as a kind of a starting point for our discussion? Agree, disagree? What do you think?
And this is even in the interview before the trip or whatever. It's just to feel
absolutely.
them out and see what they're
I think that's mandatory, really. You know, you don't just take whoever comes. We can. That's one way to do it. But the problem with that, of course, is then it's difficult to really know, you know, is this someone who, you know, is really going to be, when you invest, is it really somebody that's going to adopt these things, or are they going to be always just arguing with you, you know, about what to do?
So in my world, I would train any resident that came to me interested.
Great example.
And because they're young, they've got their whole life in front of them.
And it's not in the program, so
that's
they actually
correct.
have to come to, so there's some
Yes.
motivation there.
Yes.
Yeah.
Yeah, and whereas you train everybody, you train practicing, probably predominantly practicing surgeons, probably not so much residents, I wouldn't think. And so that's a whole different set of issues, you know, with them. But as far as the motivation, I think if they're out to, like you were saying, to train others, that's key, because it's like we call it pay it forward. You know, if you pay for someone's food in that line, you just ask them to pay it forward, and it's just paying it forward. And if they have a pay it forward mindset, then I would train anybody. You know,
I like that. That's good.
Yeah.
I mean, and if you don't mind, I can pick on you a little. There's
Sure.
a great example. So she went to the trouble and the time to come to Africa, which was no small thing. So we first met in Guinea, Conakry. Had come to volunteer just for 2 weeks, and you know, to gain some experience in international work and to learn some things about other options like this MSICS thing. So, you know, that's a fair amount of motivation, you know, to some big hurdles to overcome to do that. So it really makes I think helps defining ahead of time, you know, people that really have a good reason to learn. You may not understand all those reasons, but you can tell they have some good reasons to learn.
Well, you're asking how it initiated in my mind to do this? Oh, it was way back, I guess, in medical school, and went to Tanzania and worked at a leprosy center, and really wanted to do something that would make a big difference. And my husband at that time was a vascular surgeon, and in one of the surgery journals, there was an article from C actually about people who'd come back and done cataract surgery. And it's actually at the very I read it the last week of my medical residency. And so for my exit interview, I told my department chief, well, actually, I think I'm going to do ophthalmology. And because it seemed like it was just more clear-cut, more defined what you can do for people. And I'd always had a heart for missions. And I know I'm older now, but I still have some time to still give back. And so I'd like to use that time.
I think
To
I
give back.
probably win for older in this room. I'm not sure how old you are, but I bet you I'm the older. So
Okay.
you're not
But,
older. You don't
no,
count.
So I'm kind of determined to use the time that I have to just do as much as I possibly can. And that's what motivated me. And I just enjoy it. I enjoy working with my hands.
Sure.
So it just fits me very well. And that time on Mercy Shifts was fantastic. You know, it was great. You know, the first day I think I only did 1 or 2 cases, and then by the second or third one, I said, oh, I'll just go back to my cabin and call me if you need me. So you showed some confidence, which helped a lot. And then I was doing 10 cases a day shortly after that. So it was a very positive, encouraging experience. And I just hope to do more of that and go on missions more regularly. I've gone about once a year the last 5 since then, but I want to increase that frequency, and so that's why I'm here. And then, as you know, I was invited to teach in Nigeria, so that's why I'm here too.
Would be fantastic.
Yeah.
Let me just give you go through these fairly quickly, because it'll maybe set the stage for the discussion, some of the specifics. So I've been doing this MSICS specifically. I've focused all my efforts on MSICS for a variety of reasons, but I won't go into. But basically, I came from a general ophthalmology practice as a phacosurgeon, just like you were talking about, and left my practice. Started teaching MSICS, and I saw a lot of potential for that. I didn't really know much about MSICS. I had no idea that that's what they were doing. I didn't know what Aravind was. I'd never heard that name before. I didn't know anything about any of that. But I saw this technique, and it wasn't even called MSICS at that time. It was just small incision. They called it cataract surgery, and the literature had all kinds of different acronyms for it. So if you tried to find anything in the literature about it, I don't know, it was sort of hard to find things because there was no generally accepted name label for it. So anyway, I got involved in it, and then in 2004 I left my practice altogether to just do this full time. So I really wanted to invest, in other words, and made a fairly significant commitment. So over the 12 years since 2004, not counting the time before that, but the 12 years when I've been doing this full time, I've trained 16 phacosurgeons, including a DSEC surgeon, a retinal surgeon, 23 extracapsular surgeons. So those are people from other countries like we're talking about today that have that background of doing that traditional type of surgery, but not much other experience than that. And then 10 trainees who had not had any surgical experience with ophthalmology. So I call those the ab initio trainees. And so let me give you the sort of the flow of what happened. So as I was training people, I was looking for not what do I do the best, but what can I teach the best. And I tell you, that's a different mindset, because in one case you're looking for how can I be the fastest, coolest surgeon that I can be, and the other is how can I help, what can I use that will help my students be the very best surgeons that they can be for the most part. What gets them started? What's the best way to get people started? So I fairly systematically, as my obsessive nature is, kind of went through all these different techniques, because then I started to find out there's different ways to do this. And so the Nepal thing with Ruit and the fish hook, and Hennig, that's I believe who championed that, and Blumenthal, who ran around the Academy of Ophthalmology with his new book that had his his pictures of all the stuff that he'd done in Israel, and the teaching that was sort of the foundation for a lot of the work that was done, which then was incorporated at Aravind. The Peter Kansas technique. So I don't, was he actually in Kansas, or was it just Peter Kansas? I can't remember. I think he was actually in Kansas. It was Peter Kansas in Kansas. So it was, yeah. So there you go.
Makes it
so,
easy.
Yeah. The Mexico lasso. I don't know if you ever, woohoo, it sounds very Texas-like, right? There's the lasso technique. Are you familiar with this one?
Yes.
Yeah,
Yes.
so-
Even did you see the new device? They are advertising right now the My Loops.
Yes.
It's some of the same.
Yeah, it's a proline thing you put around and then you just pull the handle back and it cuts
And
the,
cuts.
slices the thing in half so you can get it out through a smaller tunnel. So I looked at, and I used these techniques for, at each one of them, I did at least 100 cases. Some of them I did quite a bit more than that, but I did at least 100 cases, and I sort of put myself in the trainee's position. I thought, what are the challenges that a trainee is going to have with these, and what are the best things that they can do? And what I wound up with is sort of a mixture of a few things, basically. And now I don't know what my technique is, I guess is what all that means. I have no idea, because it's really not about my technique. It's about what it seems to work well to communicate with people who are learning this in a fairly reproducible way. Not all the time, but at least fairly reproducible way. So I do use a crescent blade right side up and do a kind of a curvilinear groove, but it's not at 12 o'clock. It's not temporal. It's sort of offset. So the temporal approach is pretty hard to do for a new MSICS surgeon, I found. So instead of forcing them to, well, you got to learn how to do the temporal approach, instead of forcing them to do that, everybody sits at the head, and then I have less problems with the left eye, right eye transition in a room, you know, because you can't save all the right patients for the first half of the day and all the left eye patients for the second half of the day. All that kind of stuff goes away immediately. So I chose this super temporal sort of approach with the right side up with the crescent blade, about a 7.5 millimeter external, 8.5 millimeter internal, with the paracentesis on the left. That was also strategic. Aravind people just fuss all the time about this. Well, they all want to do the paracentesis on the right. I said, well, phacosurgeons don't do the stab blade on the right. They do it on the left, don't they? And I said, so how are you going to learn? How are you going to learn the skill with your left hand of controlling that, where the tip of that blade goes? You know, because you know what happens. You wrong place, try again. So you stab the eye about 3 times before you finally plant it and get it, you know, for someone who's just learning. So do it on the left, and it's very safe. It doesn't hurt the patient. That takes a few tries to get it where you want it. But in the meantime, they're coaching their left hand. So I was looking for something for surgeons to enhance their left hand, because what common denominator of many of these surgeons in the developing nations, now remember I'm training both, the phacosurgeons and the developing nations, are common denominator for them is they've never used their left hand at all, right? They use a bridal suture. So the consequence is they grab the eye with the left hand and they don't move. They just hold it right, dead still, right? That's all they do. There's no feeling of bimanual technique whatsoever, right? So they need something that helps them learn how to get that delicate microsurgical control to them. So that's why the paracentesis on the left. So at first blush, you know, so what's the big deal about the paracentesis on the left? Well, there was a reasoning for that, and it was so they're learning a microsurgical skill with the left hand that's very safe to do it that way. A viscoaqueous exchange, and it's so rather than just injecting viscoelastic, the concept is they learn dynamics, fluid dynamics. So the phaco machines control all that for us, right? So you put the foot pedal in, and the magic happens in the box, right? Woo! And so you may change some settings, but you don't think about that. Well, they don't either, and so they think the machine is magic, that somehow it makes everything work, and it doesn't actually. But they need to learn how to think about the fluids in the eye. How much fluid is there? What happens when there's a thick fluid and a very watery fluid? There's the aqueous versus the viscoelastic. How do those two things interact? How can you use the denser fluid to manipulate tissues? And all those things are very simple concepts, but unless they focused on them, and that's how I use the viscoaqueous exchange step, is to help them learn those things. So I'm not teaching how to do a viscoaqueous exchange. I'm teaching them fluid dynamics. So, and you'll see with each one of these steps, that's how I process this and where I wound up with a technique that has to do with it. So the keratome entry is not just about how to use the keratome blade. It's about how to manipulate blade angles to stay in a particular path. Because what happens? Exactly. So, because what happens is very often is you don't think about that, and they're used to phacosurgeons, just one stab and they're in. That's it. So the whole idea that now you're going to extend, to the left and to the right, and so on.
Try to keep the same plane, because sometimes
you pass the microphone.
and how to keep the same path, not to
Yes.
do a bottom hole or an anterior entry. You have to keep that in mind when you are doing your MSICS incision. That is good for me.
Yes, absolutely. And so the mechanics of how these blades work, you don't have to think about that too much if you're just using one blade to do one 3-step incision, and that you're in. That's all you need. So you can do that pretty much without really understanding even all these things. But now we're talking about using those same blades that they're used to thinking of a certain way. They need to learn to think of those blades differently. The phacosurgeons do. And the extracapsular surgeons haven't ever used a blade at all, right? So they're learning how to now we're not talking scissors anymore, to open the extracapsular sort of scleral corneal scissors. Now we're using a blade and making a tunnel. So learning the mechanics of these, the blades, the shape of the blades, and how those shapes impact their functionality is a very important thing. And once you get that, then you're able to start applying that to different situations, because that's where it's always difficult. No patient is the same. You can't do cookie cutter surgery. It's just not possible, which has been one of my huge challenges with the simulator project that I've been working on, is that in some ways, it's a cookie cutter thing, but it's actually part of what I think we've achieved, and is that you don't feel like it's cookie cutter surgery when you're doing that, because it has such a range of responses. The features allow you to actually go wrong in a lot of different ways. You can't just do one thing and it always works like you think it's going to work. So anyway, that's one of the challenges of simulation, is for the level of realism we need to allow you to learn the mechanics that goes along with cataract surgery. It's a pretty high level of sophistication to do that, but making progress on that. And, the can opener capsulotomy I've also chosen as the fundamental thing, and the reason for that is that it teaches the dynamics of the anterior capsule itself and how it relates to the cataract. The capsulorhexis, I did that for years. In fact, I still have my secret week when I get out the phaco machine and I do standard surgery. Don't tell anybody. That's what I bring the phaco machine in, and we've saved up. I think you remember this, Ann. You were there on one of those weeks, but you were sworn to secrecy that you would never tell anyone I did a week of phaco surgery just for fun. And so, certainly believe that's a great procedure, but it doesn't get across what they actually need to know for managing these cases, whereas the can opener does. And so here's the challenge. When you say the word can opener, it's horrible, bad, evil, bad surgery. So the challenge was to recast the concept of can opener capsulotomy into a fresh perspective. So this is not can opener like your grandfather did, is what I always say. This is can opener. This is modern can opener capsulotomy, and there is a vast difference in how the capsulotomy works.
I find so hard that the phaco surgeons, when they come, they make their capsulorhexis. They want to do capsulorhexis because that's the best surgery, but they're making them too small.
Too
and they
small.
can't get the lens out, and they just struggle with that.
Absolutely.
And also they bring all the bag with it, and you have a beautiful intracapsule.
Yes.
Yes.
Before the lens goes
Well
down.
done. Nice intercap. But yes, so, exactly. So the dynamics of what happens when you actually have a dense cataract and it's shaped like this on the surface instead of, our softer cataracts that we have here, and you put in viscoelastic and you can create a concave surface. And when you tear a concave surface, it acts far different than when you try to tear a convex surface, doesn't it? So, they're trying to tear this convex surface because, that's what they've always done. They think that CCC will work the same, and it doesn't. The can opener is ideal for a convex capsule. That's the point. And whereas CCC is ideal for a concave capsule. And so once you get that concept in your head, then it becomes far easier to learn the dynamics and make these tiny little feathery scratches, So I'd make about 30. The traditional can opener was like 8. Drag it, drag, right? You remember?
Oh, yeah. You put the lens lens out.
Yeah, basically.
You just, like a pimple.
Yeah, that's right.
So I learned it, the old technique too, a long time
Yep.
ago.
So this capsulotomy, though, is using very small, little oriented always so that they're pointed towards the center, and it's amazing how well and consistently that works for a broad spectrum of different types of cataracts, and that's the point for training. So I don't have to learn 8 different ways to do a capsulotomy in a stressful situation. I can learn one type of capsulotomy that is very adaptable, very useful for a wide range of pathology. So that's why I chose that. The rotate and hydrodislocate issue. So now you've got the larger opening, but now how do you deliver the cataract into the anterior chamber, or do you deliver the cataract into the chamber? Now, of course, the phacosurgeons hate delivering the cataract into the anterior chamber because that's that's the thing you don't do, right? You want it
too close to the cornea.
too close to the cornea. You want it to stay behind the pupil. So the thing that's helped me with this rotate and dislocate is the idea that you're actually rotating the nucleus into the tunnel in one step. So it's the fish hook is underneath. You go underneath, you turn the hook up, and you pull it up, and it pulls it right up into the tunnel. Well, it turns out you can do exactly the same thing on top of the lens, but now you don't have a sharp needle behind the cataract, right? So training-wise, I think it's far safer to teach this rotate approach with the needle on top of the eye rather than the fish hook, which is underneath the eye. Not to mention you have to make your own fish hooks and all that sort of stuff. Which is,
I had one surgeon do that, and they get disoriented where the tip
oh,
is.
oh, fix my heart.
Say, I don't know where the tip is.
I don't know, man. I don't want to. I don't want to go to bring a sound nucleus in the retina.
No. Oh, yeah, that's right. So again, it's a way of thinking about these surgical steps that's geared towards the trainees, not towards some thing that you now have labeled or what. I mean, everybody wants to put their name on something or whatever. You know what I'm saying? So it's about about what works best for the student. The lens loop delivery. There's so many different ways to do that. There's visco delivery and hydro delivery and so many.
I use Vectis. I really
Use
like
Vectis.
irrigating Vectis.
Yeah, irrigating vectis is a great way to do it.
I really like that.
Yeah,
I love that.
yeah. So you inject, or do you don't use a?
No, the Blumenthal maintainer, no. I just go with my syringe. This is the idea when I was talking about how to use your left hand.
Yep.
Because I open my wound, the anterior lips in my wound, go under. I fill the chamber with viscoelastic tapon below, and when I stop the nucleus in my wound, I start to irrigate.
Mm-hmm.
Also, I taught to my assistant how to hold the eye in the opposite side. In that way, I don't use maybe for 10 years the brightly suture.
Yeah.
Because it's more money. I'm sorry. It's more money, and also it's more risky to have ptosis.
Yeah.
But this is I really like that. But also I
Yeah.
use the visco expression when it is very soft
Yes.
nucleus.
Yeah.
It's not a big deal. I believe it's the best way in that specific scenario you will use to take out that nucleus. That's
Yeah.
it, with not harm to the endothelium.
Yeah.
I always say, up is not God. Up is the endothelial cell, and when you damage, you will need a cornea transplant, because you can say, Diego, you are an army and it's dissect. Where I get a tissue for dissecting my country.
That's pretty good. Up is not heaven. All the different ways that you can do this delivery is, they use the bridal suture. The surgeons who do it with the bridal suture, they like to pull on this bridal suture, which rotates the eye down and raises the pressure in the eye a little bit. And so I did a little test. So I had a surgeon who was just determined that was the only, they just couldn't possibly do it without a bridal suture. Said, okay, let's just do a test. I'm going to do these 20 patients over, without a bridal suture, and you go ahead and do your, he had like 5 or 6 patients, every single one of his patients. So we stood in the hall on the first post-op day, and I looked down the hall and I smiled because I knew I could see exactly what had happened. Every one of them had ptosis, and you could see them lined up on the left side of the hall, where his 6 patients, or their eye was all drooped down like this. And on the other side, not a one of them did. So I said, "What? Can you tell what happened?" And he said, "No, they all look fine." I said, "No, look again. Look down the hall. Just tell me what you see." And he had this. We got this little sheepish grin on his face, It was like, he's got to realize what had happened. That oh yes, it does have this impact. So anyway, sometimes you find teaching tools that are, to help people learn things. Sometimes you have to find ways to help them see what's right there in front of them. And I always talk about that with this lens loop thing, is in the bridal suture, because that, to me, was such a great example. He just would not believe it until he had the patients on the right side of the hall and the patients on the left side of the hall, and there was a clear difference between those, how they looked. So let's see, the Simcoe cortex removal. Of course, this is where so many of the surgeons get into trouble. The phaco surgeons who are learning, that where's my foot pedal? Yeah, and how to use their thumb efficiently. They struggle with that, and they sometimes, if you make sure they have the right size syringe, some of them want to use a very large syringe because they're sucking large amounts of fluid, from through the Simcoe, and so they're always having to, clean out the syringe. So they're stopping over and over again. So they, work for a little while, stop, blow stuff out of the syringe, stop, work for a little while, blow stuff out of the syringe. So every time they're doing that, it's more stress on the eye. So one of the things I found that works pretty well is you don't give them a syringe that's big enough to do that. So they're forced to have to think again about how they're managing the flow, that's going in and out of the anterior chamber. So, a smaller syringe, 5 cc's at the largest, that's like half full of fluid. And they understand, they have to learn that the left hand is not just about aspirating, it's about injecting. And a lot of what you do is irrigation with the left hand, right? Not just aspiration. You spend a lot of time irrigating. And that little pulse. So the other thing I do is I show them my thumb. I have a callus. I have a callus right there on my thumb.
Of course, you play guitar too.
Well, but you don't use your thumb on the guitar. These fingers have calluses from the guitar. This finger, the thumb, has a callus from the INA syringe. That's exactly right. So it just says there's a lot of movement that should be going on with that syringe. And if there's very little, when I'm watching them, you can see this looking across the room, watching them across the room. They're not interacting with the fluid flow very well. This drag and drop idea is, it's engaging cortex, pulling it to the center, release, and it just washes out. Engaging cortex, dragging it to the center, and release. So it's this repetitive cycle that starts this machine-like flow in the anterior chamber that loosens cortex, and a lot of times things that, that normally you might have to work pretty hard to get at, that the novice surgeon finds that it's sort of a little more forgiving. It releases sooner, and they wind up with a cleaner capsule because they haven't had to spend quite as much time, going after each little strand of cortex. So it makes it faster, it makes it safer, I found too.
So
What
you don't
do
have
you?
as many flat chambers and
That's
stuff like
right.
that. You're not going back and forth because
That's right.
you're not taking the Simcoe out of
Nope.
the eye so much back and forth. It's dragging it all the way out. You're
Nope.
staying there and back and forth and letting it flow out.
Mm-hmm.
Well, that's good.
Yep. The flow from the gravity side.
Yeah.
If you're not getting any washout, then your bottle might be too low, because that's the other common mistake is the irrigation bottle. If it's not high enough, you might not get enough flow, right? So,
In my what do I do in that case? First, I found the perfect Cinco. The perfect Cinco is a company. I always in my country have to think in price. It is really expensive because it's like a $20 each, because normally you pay $5 for the regular Cinco. But from Indo-German, they have really high flow, really high. It's very thick when you put this thicker IV tubing, and you have a really high flow inside the eye. That is first. Second, I enhance with a driller a little bit the hole, and you have a better suction. Also, I do the same like you do. When I said, if you go through the main one, just pull and leave, pull and leave, pull and leave. Because one of the biggest concern when you are doing irrigation aspiration, the chamber start collapse. And every collapse, I said, next day, you will have fold in your cornea.
Yeah.
And then I just grab, pull, grab, pull. Also, sometimes we don't do a really good hydro dissection, and it's very stuck. You know, and I found if I make a wave with my viscoelastic, I use very cheap viscoelastic from Arabian, $3 each ampoule is 2 cc. I can use, I am a really rich doctor, and I use a lot of viscoelastic. I was trained for a cornea doctor. He always say, Diego, it's cheaper $3 than a cornea graft. And if I use a lot of viscoelastic. And when I go through my side port, I go to the right because I learned with the Arabian technique. I be more aggressive because if my IV tubing can put in the ceiling, I put in the ceiling. See? Because I need a lot of gravity. When I go, my chamber is right there, and I go very easy and aspirate. It takes less than 1 minute. But I use viscoelastic I use gravity, and also if you go to the main one, just pull and leave, pull and leave, pull and leave. And then with the same irrigation, the fluid inside the eye, just push a little bit the posterior lip of the one, and you clean everything.
Yes, that's right. I think you said a very important thing, actually. Several important things, but one thing that especially struck me is what I was thinking of is that tubing issue. So here's the situation. You go into a training place or go into a place they're going to be doing some cataract surgery that they don't normally do cataract surgery, and they've obtained some type of materials to do that. So the tubing that has the larger diameter is more expensive. So most of the time what people get is the small tubing. Yes.
From China.
That's
Ran into that, and they're shorter.
Yes.
They're like Alcons are longer.
Yeah, so you
the
can't get
bottle height.
you can't get the bottle up, and you'll notice if you watch the tip as the fluid flows out, it's like brr, it's just barely, barely coming. It ought to be shooting across the face, So an easy test, and again, this affects the novice surgeon or the one who's just learning this. They're working against a terrible handicap if the flow is not adequate. So that tubing is no small thing to keep that in mind. And then the C-loop IOL, the rigid lens, not a foldable lens, if you can at all help it, I think really helps. So here, what I was hoping to achieve and I'll finish up my section here so you'll get going with yours, is my goal. I had some specific goals, and that's why I present this. You could have any goals, but I had some specific goals, and that's my point, that for training, it should be objectives based. Right? If you have no objective for your training, then you may achieve anything. If you have no target, you will hit it every time. It's just that simple. So I was determined that I would have some objectives for training, and that is, I chose two. One was that that the surgeon, once they had finished their training, would be able to operate efficiently with the 5% or lower complication rate. So that was one goal. And the second is that they would walk away with subjective confidence that they would know how to solve various problems. And so my hope was that they would know enough of the concepts to be able to solve problems that would occur when they weren't, in a training situation anymore. So those were my two objectives. So I wasn't interested in I didn't think people needed to walk away masters of MSICS. No, that wasn't the goal. The goal was that they'd walk away with some specific a competence level that was about 5% and confidence to be able to move forward. So here's what I achieved. So I had 16 of these, and this doesn't count this past 2 years. There's several more now, but the number of cases to achieve confidence, it took about 30 to 40 cases for tunnel construction to get to that those two objectives. and about 80 to 100 for anterior chamber management. Interestingly, they mastered the tunnel faster than they mastered the anterior chamber management. Interestingly, the DSEC and retinal surgeons both had much shorter learning curves. They really did good. The anterior segment surgeons, not so great, but the retinal surgeons, man, they were stars. I couldn't believe it. They did really, really great. The extracapsular surgeons, so there's 23 of those. So it took about 100 cases, 100 to 150 cases in these 23 surgeons was the range to achieve that 5% or less complication rate. And subjectively, they walked away and said, I feel really confident about, and I could tell that they had that confidence. About 150 to 200 to manage the anterior chamber, so closer to the same number of cases to get those, interestingly. And there was also some surgeons that didn't achieve the training goals at all. They never got there. Part of the problem with basing your training on objectives is that you may not achieve the objectives. So there's a good side and a bad side to the whole objectives thing. The ab initio surgeons, there's only been 10 of those. Took them about 150 to 200 cases to be able to do the tunnel competently. About 300 to manage the anterior chamber, and 2 of those 10 were not able to achieve the training goals of competence and confidence. So overall, about 3 times as many extracapsular surgeons, 3 times as many cases for an extracapsular surgeon to get where they needed to be. But about 400 to 500 cases, I think. I've talked to a lot of trainers, and I haven't talked to you, though. I'd be interested to hear. My general impression is people feel about 400 to 500 cases to get to the point where you really have mastered the issues with MSICS. Would you agree with that number, or fewer, or more, or what do you think?
I believe the number is good.
Yeah.
But as you said, many doctors, they are so skillful,
Yeah.
that the first 10 cases, they're master. But 3 months ago, I had my worst experience in my entire life, and we did like 50 cases with one doctor. He never learned. I mean, the number is a rate of cataract surgery is good, but also we have to individualize every surgeon. But I think 400 and 500 cases, it is a good number because you are faced to different scenarios. Because to do an easy case is the most simple step. But when you come to difficult cases, you need that experience to solve that specific problem at that specific time.
Yeah. Well, I think that raises an important point. It's very rare that I've found myself saying that someone would never learn. So the issue is, if you have objectives, the issue is, did they achieve the objectives that you had in the amount of time and the number of cases that you had to offer or not? That's it. It's not, could they ever learn to do this? That's not the issue. The issue is, did you achieve, you had some specific objectives you tried, did you or didn't you achieve those things? I think that's valuable to have set those goals. And sometimes it takes several things or different trainer. I mean, there's other issues, I think, here. What do you think about that?
I was just going to say, in the world of simulation, we study, especially on the IC simulator, which is more for phaco. We know that nationally, the residency programs, if you take all the PGY2 or first-year ophthalmology residents and you look at the data, what they do is there is definitely a subset of residents who will take less tasks and less time to achieve the endpoint of completion successfully and really good, and then yet you'll take the other group and there might be a skew of some residents who take maybe double that time to get to the same point. They get to the end point. They get to that point of what we call competency, where they complete all the tasks successfully, but it has taken them in their journey much longer. And it doesn't mean that we're judging them. We're just noticing that the skill set is different among some of these, and this is the young surgeons.
And I think that's really important as instructors to kind of have a perspective on that. So you'll be going to Nigeria, and you'll only have how many weeks that you'll be there? Oh, so that's a tough deal then. So only a week, and you're going to try to instill some skills while you're there. So that's sort of one of my nightmare things. In fact, I don't even do that anymore because it's like hard. So having objectives for training, and basically you're saying you just don't have the time in the cases to do it, is what that would mean to me. But you got a great opportunity, and it's just worth bearing in mind with this discussion. I think it's very important for a situation like that, because it means you're just a little piece of their training journey. And that's good. That's still fine. Yeah.
And that's the same with me. I'll lead a 2-week trip, and I have 9 surgeons, so they each get 3 days in a 9-day thing.
Great example.
And to get 500 cases is going to take them 10 years, doing a long time. So we just are just a little piece of that. They're doing maybe 10, 15 cases in their mission trip, and they've done none before, or maybe they've done one other trip. So we're just a part of that, and it's hard to really get them to a competency in a short term. Maybe if I've seen them, they've done 5 trips, then they're much more confident, and so I get a whole bag of different experiences and stuff like that. So, but I think one of the things I know is just to encourage them and coach them and say you're doing fine, and this pat them on the back type of thing is really helpful, so they don't get discouraged, because we want them to come back. A lot of them will come and don't like it and won't come back. So, just helping them get through the steps and being somewhere on the process of them learning this technique, and usually it's 1 or 2 little techniques that I can show someone that might help them. Get past this little struggle that they have. And that gives them, they're on that learning curve of getting the competency of being comfortable with it. So, and the skills you're talking about are very helpful in doing that.
Well, let me finish up here with my, as I said I was going to do that, and I still haven't done that, so you could get started on yours, but just a quick overview that'll help, I hope will inform our further discussion. So there's 3 tasks that are well known to be part of any skills training. First is the complex task training. That's the skill itself, the knowledge to do the skill, and the attitude required to do it. So the SKAs, they're called in instructional lingo. You talk about the SKAs for complex task training. And what this means is that this is not an accidental thing. Training is not an accident. It's very purposeful. It's something that's very carefully orchestrated, or should be very carefully orchestrated, so that the interactions are positive and reinforcing. And even when with short-term things, which I think is an important challenge for us to think about, how do you take advantage of the shorter, or a week in Nigeria, how are you going to take advantage of a week in Nigeria effectively? So that you really are giving them something and not wasting their time, your time, and so on. I have an advantage in that, I'm going to be 7 months in Cameroon. Well, that's a different situation, much different, and so I can approach it a little differently. But that doesn't mean this isn't important. So I would be love to hear some discussion about how you can orchestrate these things to be a good learning experience. That's relevant to those particular settings. So it's a complex task. But it's a skill that can be taught. So I think if you have instructor surgeons, in your setting, then working with them, getting them together to form some sort of a working group on how are we going to take advantage of these short-term trips or things like that. Here's just some examples of the skills that need to be taught. So how to be present when you're in the moment, in surgery, and not wander off in your mind. Trainers tend to do that because it's not their case after all, and they don't feel the responsibility sometimes. So they're doing the texting on their own. Just it looks okay. Yeah, he's still okay. So that's not the way to do it. So the Socratic method, where you're really getting them to explore, to think about what they're doing, asking questions rather than just always providing answers, facilitating. Learning to be, how to be clear in what you say. Think about what you say before you say it. Don't say the wrong thing, because it takes a lot of words to undo the wrong idea, right? So I have tried to work on that over the years, because I've stepped in those holes big time, and then I spend hours trying to undo what I said, because the principle in learning is you tend to remember the first thing you learned. That's the principle. So very important to not learn the wrong thing first. Otherwise you spend a lot of time digging out. Knowing how to anticipate and think out loud. with people while they're working. So you're processing things like you're their personal computer assistant. You're reflecting on the mechanics of what you see happening, or can help them see things they don't see, like we talked about earlier. But that means that you have to develop skills at being able to know what's happening before they know what's happening. So I've practiced that, actually. Wasn't naturally good at that, but I can watch a screen now, even a simulator screen, and you saw me do this when you tried it out. I said, I bet that's going to be a little shallow on that side. Even though I was watching it in 2 dimensions on a screen.
That's because it was more difficult.
Yes, so I could see the difference in the mechanics of how you were doing it. Things slowed down. There was a little more, in uncertainty. Yeah, a little more uncertainty in how you were moving the blade. So I could see that without even looking through the microscope. Those are the little observations that a keen trainer knows how to take advantage of for the benefit of his students. And then being sort of that transparent third hand. They don't know that you're helping and how much that help really matters. But then you can gradually withdraw it too without them knowing that you've done that as well. But if you are always saying, well, let me help you with that, if those are the words you're always saying, that's not what I mean. Because then they're very aware that you are affecting everything. But if instead there's a little tip that shows up in their view, but they don't know where that even came from, so to speak, and the cornea stays wet, but they don't know why, and the eye is in the right position, but they may not know why that is either, but they don't care because they're already worried about other things. That's the transparent third hand idea. And then when you withdraw that, they also don't notice it. So I think it's a very clever approach to being involved personally in the case. The knowledge, you need to know the mechanics at a cause and effect level, and really understand these patterns, the peaks and valleys. So there's the grace period. The first 10 cases, they think, I'm an ace M6 surgeon. And then the next 50 are horrible. So it's this very predictable pattern that I've seen anyway, that the end of the first week of surgery, not to discourage you because you're becoming a physician, so the end of the first week of surgery is like, oh man, I don't know if I have any business doing this anymore. Because it's like what started off good, then he's laughing because he's seen that too. So
I experienced it myself.
yeah, so then the nosedive happens. Exactly. But then the second week, this magic thing happens. It's like something has been processed, and I remember you stayed in your room. I think is what happened, if I remember correctly. It was over the weekend or something like that. It was like you were just like reflecting on what you were doing. I think I remember you describing that to me. Yeah.
Yeah, I took copious notes.
Took all these notes, but then it's notes on a page that had to get into your heads and then ultimately get into your hands, and that was a weekend's effort to do that. And so by the next week, things were much better. But it's like magic, it was much better. It was like you went from not so good to much better with nothing in between. How did that happen? Well, it was like this processing time. So anyway, that's the patterns that I'm talking about. Know what the sources of stress are to be able to anticipate those, recognize cues that predict problems so you stay on top of things, and learn some attitudes that they either hear or catch, right? A lot of attitudes are caught, not taught, as they say. So that they understand that you have a great deal of respect for life itself, and that this is a patient, this isn't somebody you're practicing on, and that you have a concern about them, about their life, about their family, about the patient, about their life, about their family and their vision and so on. A code of service that's sacrificial, and have a certain level of confidence. I think trainers, it's important that they know you're confident about what you're doing. So it shouldn't be sort of that false humility thing. Well, I don't know what I'm doing. So it should be a confidence that's born out of the experience that you have, but then learn how to depend on wisdom and not power, because that's the problem in many places. Right? You'll just do it this way because I said do it this way, and that's the only reason to do it this way. So yes, and then be committed to the success of the trainee. And of all those things, probably those last two make the biggest difference in my training practice, I would call it, because people know that I'm not trying to just tell them what to do. I'm really trying to help them understand what's happening as best I can, and sometimes I don't know, and I'll say that if I don't. and committed to the well-being of the patient. So, so it's a complex cross-cultural experience, but it's these things combined that really makes a good skills trainer. So I'd recommend finding a technique that works best for you, just like I went through this process. That it may be something like that, it may not be something like that, but the point is, when you take the time to explore what technique works best for you for training, when you're sitting in the trainer seat, what technique should you be recommending? It may not be the one that you would normally do. So when I just working by myself on my, secret weeks that, it looks quite a bit different than when I'm training, so that's why that is. And study what you do just like your own surgical technique. These are techniques too. And then work on these specific skills. And remember, it's not an accident. And you're as much the student as they are, and just had to put a plug in for simulation here. Like you mentioned earlier, this is the simulator I've been working on these past 5 years. And I really do believe, the reason I've done that is I really do believe it's going to have a place as an important tool for us as instructors to use. So that's it for me, I think, yeah.